Okay, everyone, good morning. My name is Megan Williams. I am the Director of Support Services at Alzheimer Group. January is Alzheimer's Awareness Month. This year, AGI features a series of lectures to raise awareness and demystify misconceptions of Alzheimer's and other forms of dementia. AGI provides support for people living with dementia and their families. Our services include in-person and online activities, family and individual counseling, education, and support groups for caregivers. Today's lecture is made possible by the generous support of the Lasner Learning Center. AGI is a charitable organization and we rely on donations of supportive donations. This is a free lecture, but you're welcome to donate at any time by calling us or visiting our website. Today's lecture, everyone will be on mute and you can use a Q&A or chat function at the bottom of your screen to ask questions. At the end of the presentation, either Nin, our outreach coordinator, or I will be reading questions to Dr. Chiu. For today's webinar, we have the privilege to have Dr. Chiu present on the D word, demystifying dementias. Dr. Chiu is an assistant professor at the Geriatric Medicine at McGill University and a geriatrician at the Montreal General Hospital, McGill University Health Centre. Her work primarily involves multidisciplinary assessment and rehabilitation of frail elderly at the MGH Geriatric Day Hospital. Welcome, Dr. Chiu.
Good morning. Thank you for this opportunity to talk. Everyone can hear me and see my screen, yes? Okay. Yep. All right, so the D word. Many of us may remember back in the day when the C word was the word we didn't talk about, right? Cancer. Oh my God, we don't talk about cancer. It's so shameful to have cancer, so on and so forth. Now we're doing like fundraisers in the street. You know, we have pink ribbons, we have little prostate stickers, we have all kinds of stuff now, right? We talk very openly about this. Memory issues though, the D word, dementia, or the A word, Alzheimer's, still unfortunately carries some stigma. And I think that's part of why there are these awareness months, there are these public outreach lectures and so forth, is that, you know what? Memory issues or cognitive issues are just like any other illness. They're like diabetes, they're like cancer, they're like high blood pressure. And if we talk about these things, there's less stigma about it, then we can live with it better. We can do more research on it. We can try to find out what more we can do to help us living with it, family, people with the illness, and so on and so forth. So hence why I say the D word. We'll just talk a little bit about what is dementia, what it isn't as well, and then try to touch on as much as possible with the time available, what can be done about it. I don't have any pharmaceutical links. I don't have any links to any of the organizations that I may mention in this talk. However, I do, and I have had family members who've had various illnesses that in one way or the other did affect their cognition. So all that to say is that, you know, yes, I look at this from a professional point of view, but I've seen things from the family side of the fence as well. So I'll talk about the brain and some of the terms that are used when talking about memory and cognition and so forth. How exactly, what is the process to diagnose dementias? Brief overview of the different kinds or the most common kinds that are out there, as well as this phenomenon they call behavioral and psychological symptoms of dementia, Bpsd. The typical course with the huge in red, in italics, caveat there, what I described does not mean that it will happen to everyone, that it will happen at all or necessarily rapidly or what order and so forth. Everybody's situation is different. We'll talk about some of the treatments and some other issues to consider, and then review some of the resources that are out there for you living with dementia as the person, him or herself, or family. So our brain. Well, the good news is we have a lot of brain cells. The bad news is that the maximum brain cells are when we're born. and then it's all downhill from there. No, I'm kidding. So the actual number of brain cells are the maximum when we're born, but the rest of our lives is spent re-networking those brain cells. It's nice to have cells, but it's really what's important is how they connect and how they communicate so that our brain can do the things that it needs to do, okay? So there are certain things that do change with aging. What can we say? The number of brain cells do decrease, but again, there's that networking and re-networking thing to help, the cells that are there work maximally together, what sometimes is called the plasticity of the brain. Yes, it does seem to be normal that our speed to process our thoughts, to register our thoughts, to retrieve info from our memories, from our brain, is slower as we get older. But it's that classic tip of the tongue phenomenon, right? Like, what's that word? Oh yeah. And then typically like 5 minutes later or at midnight when you don't need the word anymore, boom, it comes back. That can be quite normal, okay? But the flip side of this, of course, is that as we get older, we get a heck of a lot more knowledge, experience. We can use those brain cells much better than somebody who doesn't have that knowledge and experience. So what our brain does, of course, is very basic life support. It controls our breathing, our heartbeat, our blood pressure, our temperature, our swallowing, sort of just the very basic things of life. But it obviously controls things like physical movement, sensation, how we perceive things, vision, hearing, all this kind of stuff. But then there's this realm of cognition, and we often, myself included, often say the word memory, but cognition is so much more than just memory. It's all these other higher brain functions. So when people talk about cognitive impairment, cognitive problems, that kind of things, memory is definitely one of the higher brain functions, but there are other things. So for example, language and calculation, for example, these are definitely higher brain functions. Sight and perception of things in space, visual spatial perception, as they say. Things like learning, remembering, feelings, judgment, behavior, all these kinds of things are all the higher brain functions that our brain also does. So when we talk about cognitive impairment, yes, memory is the thing that we think about most commonly, but it can also be things like language, visual spatial, judgment, behavior, feelings, that kind of stuff as well. So some of the terminology you may hear used. Cognition, I just mentioned there. Normal, what's normal, okay? Normal means, okay, we're not really concerned. The person themselves is not concerned, family is not concerned. We don't have any evidence that there's any problems. Things just seem to be that normal, those occasional senior moments that we have that really don't have any consequence, okay? Then we can get into an area called subjective cognitive impairment, where the person themselves feels like something is off. But when you actually test the person, or if you ask people in their entourage, things seem to be okay. They seem to be doing everything that they normally do. Work is fine, social life is fine, daily life is fine, but the person feels something is off. Sometimes that's what we call the worried well, that there is actually no problem, but for various reasons or for some other issue going on, which I'll come back to, like depression or things like that, the person feels like their memory particularly is not so good. But sometimes the person may be sensing something that we're just not picking up yet. Mild cognitive impairment, more formally called minor neurocognitive disorder now, is a situation where not only is the person sensing something, but when we actually test, there does seem to be something not expected for that person's age and education level. And I'll talk about those tests in a little bit. Family or entourage may also be noticing, yeah, you know what, something seems a little bit different, but it's not to the point of causing problems in day-to-day life. The person is still doing everything that they need to do. There's no errors, there's no oversight, nothing like that. Where we start, though, getting even more concerned, though, is where it does start to have an impact in the person's life. So there's this objective evidence that something is off. The person feels it, the entourage sees it. And we have evidence now that it is affecting the person in their daily tasks, so-called functional impact. That is what we call dementia. That's just all that the word D means, okay? That there's objective evidence that is having an impact in daily life, okay? So what is that impact in daily life? So-called functional impact. At the most basic level, we're talking about the activities of daily living. So here we have the so-called basic activities of daily living, basically what you needed to get up this morning, right? You needed to transfer yourself out of bed, walk over to the toilet, dress and wash yourself, eat some breakfast, all that kind of thing. So those are the basic things. And then what are called the instrumental activities of daily living. In French, they call it les activités de la vie domestique, so domestic life activities. You need to cook, clean, pay the bills, take your meds, shop, use transportation, all those kinds of things that you need to lead a domestic life, okay? When we talk about functional impact, that's typically what we're talking about. Yeah, daily life, we're seeing a change. But more subtly, even before that, one may see impact in function at work, function in social activities, function in leisure activities. These can be much more subtle because they're not as black and white. They're not as obvious to everybody who's not in the work field, who's doing the same leisure activity, et cetera, et cetera. But people may start to see it even earlier than that. And all of this is compared to what is the person's baseline. If the person has never cooked and cleaned in their entire life and they don't cook and clean now, it's not necessarily because they've lost function. It's just that they never did the thing, okay? But if this person used to be the chef for the family and now they can't follow a recipe or add the wrong ingredients in the wrong order and all kinds of things, that's a change from baseline. That could be a functionally significant change. So just to reemphasize though, people will often tell them this to themselves, family will often say this, doctors will often say this to you. Oh, you're just getting old, you're 80, what do you expect, kind of thing. Well, yes, there are certain things that may be normal, as mentioned earlier, but there are certain things that are clearly not normal, okay? So, you don't, this is not a black and white table here. There's nuances in between, of course. You don't remember something that, took a while back, was not a very important conversation, whatever. You don't remember something that you just discussed. You don't remember something that is a very important issue to you, to others. Maybe that's not normal. You don't remember the name of, that actress in that 1950s film, whatever, versus you don't remember the names of your children, of your siblings. Occasionally forgetting things versus forgetting things that have a functional impact, like forgetting to pay all the bills. We've all forgotten to pay a bill once or twice, whatever. You're consistently forgetting to pay the bills. They're threatening to cut your cable, cut your hydro. There's a problem. Occasional word finding difficulty, tip of the tongue is mentioned. Frequently searching for your words, pausing, substituting different words, saying nonsensical words. Something is off there. And as I mentioned earlier, you're worried, others aren't. Maybe not a big deal, but now others are worried. You may not be worried, but others are very worried. We may be dealing with something more significant, not just getting old, okay? Not black and white here, this table by any means, but when you're seeing things that are more significant, particularly affecting in daily life, there may be a problem. There are a couple of other things, though, that can look a lot like dementia. And these are the phenomenons of delirium and depression. So let me talk about depression first, because people, we hear about depression all the time. A lot of the symptoms of depression can look a lot like dementia, what we call pseudo dementia, fake dementia, if you will. So somebody who's depressed can be very withdrawn, can be very passive, may say, oh, I don't know kind of thing. I don't remember kind of thing. But when you push comes to shove, it's because they can't be bothered to try to think about it. But when you really push them, yeah, they do remember. They can remember, they can think it, they can do it kind of thing. They don't take initiative to do things just because they're so overwhelmed and fed up and tired and whatever, as opposed to someone with dementia who just doesn't have that ability to do something that they used to do, you know? The flip side is that sometimes these signs of dementia can look like the depression. So again, that thing about not doing the things that they used to do, not taking the initiative to do things, oftentimes families will tell me, oh, it's because they're depressed kind of thing. But again, push comes to shove, the sadness, the lack of pleasure, the other types of symptoms of depression are not there. And when you dig more, oh, there's more cognitive stuff going on. That's more dementia. So dementia, depression, there can be a lot of overlap in the symptoms, but when you parse it down further, no, there are differences. Delirium is an important one to differentiate, to look at separately from dementia, because the causes and the treatment can be very, very different. So delirium, you can have confusion just like you can have in dementia, but this confusion tends to be new, quick onset, hours, days, at most maybe weeks kind of things, whereas the person wasn't that before. They can be drowsy, they can be agitated. Yes, you can see those kinds of fluctuations in dementia, but with delirium, it can be extreme, it can be sudden onset, and so on and so forth. And why this is important to differentiate is that delirium can be caused by some new medical issue, an infection, a stroke, a heart attack, a medication side effect, okay? So why we want to differentiate delirium is we want to see, is there a cause that we can treat now and not just say, oh, they're getting old, oh, it must be dementia, forget about it. No, this might be very treatable and very reversible, or at least stabilizable, okay? So these 3 D words, if you will, these are the other 2 D words, you may hear get discussed when dementia is being discussed. You may be asked about symptoms that are asking, could this be delirium? Could this be depression? You yourself or your family may be wondering, is this depression versus cognition? Is this cognition versus depression? Okay. So how do we diagnose dementia? Again, keeping in mind that dementia, all it means is there is objective evidence that something is off in cognition that is having an impact in daily life. So the number one way we diagnose dementia is by getting information from you, the person with the cognitive concerns or problems, the family, the entourage of this person, okay? What we call the history. What is the history of what's been going on, the reported information? There are a whole bunch of other tests, which I'm going to come to in a moment, but the key, the crux of it really is the history. That means that you're going to be asked a lot of questions, okay? And a lot of the questions can be quite personal, sometimes even asking about things like toileting, which is a basic activity of daily living, asking about finances, which is a domestic activity of daily living. It's not to pry, it's to really try to get a good idea of what is going on and is it having an impact in your function, okay? There is no, however, the history, knowing that that's key, there is no one single test that diagnoses dementia. It's a constellation of things, put them all together in a certain context. Okay, we think that this is dementia, okay? So back to that history. Firstly, is there a change? Okay? If the person has never been good with numbers and they're still not good with numbers in the same way they were before, that's not a change. But if this person was an accountant, was a mathematician, and now they cannot balance a basic checkbook, that's a change, okay? We will ask you for concrete examples. For example, in the past year, what has happened in terms of person's ability to shop, to clean, to take their pills? Have they been forgetting their pills? Have they been forgetting bill payments? Have they been needing assistance to get dressed or washed? These kinds of things, the very basic things. Has their work performance changed? Have they been told to retire? Are they socializing less? All these kinds of things are concrete things we may ask. And sometimes it's hard to think of, did things change? Did they? So we'll ask you time points. We'll say, listen, you say last summer you went on a trip to Europe. How did things go during that trip? Okay. How are things before the trip? How are things after the trip? How are things, here we are, we're January. How are things at New Year's, on New Year's Eve? How are things? How are things at Thanksgiving? That kind of thing. Concrete time points. And for family, when you're asked these kinds of questions, you can think about these concrete time points to help you situate, hey, you know what? Yeah, that's true. Last Christmas, mom was able to get, like normal, get the whole family together, cook the big meal, that kind of stuff. This year, for the Seder, dad couldn't get it together, how to lay things out, how, whatever kind of thing. You see this change at a concrete time point. We'll ask you about the timing of things. Did this happen suddenly? Has this been kind of creeping along for the past several weeks, months, years, more? Did it happen and then just kind of stay the same way? Or has it been progressing, declining? Or has it gotten better? Maybe it got better. Things got really bad when dad got hospitalized or when my husband got hospitalized, but things have been improving since then. Maybe that was just something around the time of the hospitalization, like a delirium, that has improved. And now, we're seeing that, you are seeing that there's an improvement. So not only is this information coming from the person, but the information necessarily has to come from the entourage, what we call collateral history. And it's not to insult you if you are the one with the cognitive concerns, but it's just that sometimes one does not see changes in oneself that others do see, okay? And it's awkward because sometimes we're asking people in front of each other in a family, and family are not comfortable saying these things, okay? If that's the case for you as a family member, you can always speak separately. And again, if you are the one with cognitive concerns, it's not because people are speaking behind your back. It's not because people are trying to make you seem crazy or something like that. If there are concerns that you are not seeing, it's important for your doctor, for your health professionals to know, to try to help, okay, before it does become more of a problem. Primary caregiver does not always mean the child, the spouse, and so forth. It means whomever is most involved in that person's life, whoever is most aware of how that person is doing in day-to-day life. So that might actually be, say you live out of town, it actually may be your mom's neighbor who's the one who sees on a day-to-day basis what's going on. Neighbor is the person who we need the most information from, either via you, out of town child, or sometimes we may even ask for the neighbor to come along, if the person's okay with that, to give us that information more directly, okay? Sometimes there's one sibling in the city and there's another sibling outside of the city. Outside of the city, you're the doctor, you're the nurse, healthcare, but it's your sibling who's in town who sees most what's going on. We do need to see what's going on in town as well, okay? So it's not to insult anybody or so forth, but we need to know what's going on at the front line. So typical things we may ask from in collateral history: has somebody, the primary caregiver, noticed problems with judgment, less interest? My wife used to be an avid reader. She would read like 3 books simultaneously kind of thing. And now she barely reads a book. Oh, I'm not so interested anymore. Okay, maybe she's not interested, or maybe there's something going on cognitively that makes it more difficult for her to read, process, remember, and therefore, oh, I'm not interested in reading anymore. Being very, very repetitive. having difficulty, maybe less so learning how to use a new tool, because to be honest, some of them can be pretty complicated. You know, you need to go and ask your niece or your grandkids or something. But particularly if it's something that you used before, like you no longer know how to use the TV remote that you've had for like the past 3 years. Okay. Disorientation to the date and definitely to place. You know, I want to go home. I want to go home. Well, you are home. Or completely forgetting the date. And I'm not talking about just off 1 or 2 days. You know, like today, the nurse who just snuck in the background there, you may have seen, we were kind of half joking to other, wait, is today the 11th or the 12th? You know, that's not a big deal. If I don't know though, even 2021 versus 2022, you know, I still wrote on my last note 2021, oh, no, kind of thing. But if I think it's 1957, you know, there's a problem there, okay? Trouble handling complicated affairs that you used to be able to handle, particularly when it comes to finances. That's usually where it starts to pop up. Trouble remembering appointments, particularly if you used to remember appointments. And, you know, just the fact that you have to start writing things down in a calendar and an agenda book in and of itself may not be different, may not be an issue. But if you tell me, you know, I had a professor once who told me she could remember every appointment. She never had to write an appointment down. She knew that, you know, this graduate student was coming at this time to see her and this and then and that. But in the past year or two, she started to write things down because otherwise she'd forget. Is it abnormal? Is it not abnormal? But in her situation, yeah, that was a change. And so on and so forth, okay? Again, if you're a family member and you're not comfortable saying these things in front of your person, you know, either ask to speak to the doctor, the nurse, a health professional separately, send a note, write a letter, leave a telephone call before or after the visit, preferably before, that you have concerns, and so on and so forth. But really, we don't want this to be a secret. We're not trying to hide information. We're just trying to get to the bottom of things, okay? You may be asked about other specific symptoms, or we may ask about them. And again, some of them, you know, for example, I mentioned earlier to differentiate from, say, delirium or depression. Some of them may seem completely unrelated or frankly offensive. Like, why are you asking me if I can control my bladder? I mean, like, listen, don't talk about that. That's very personal kind of thing. But there are certain types of dementias that may be associated with urine continence problems as well. May not be, but maybe. Okay. There are certain types of dementias that may be associated with walking problems, with vision problems, with sleep problems. Okay. So if these questions come up, it might be trying to help figure out what's going on. You might be asked about, has anybody else in the family ever experienced memory, cognitive, similar types of problems, particularly if you are having problems at an early age, you know, before 65-ish, we say, but particularly if you're in your 30s, your 40s, maybe even your 50s, that's something unusual. And in those kinds of situations, we do want to know, is there anybody else in the family? Because there may, or there very well may not be a link with genetics, okay? The majority of the time, there is no link with genetics, but there might be. And if there is, you know, is that something that we need to consider for the future, for other family members and so forth? But again, the vast majority of time, though, it's not linked to genetics. You may also be asked, in addition to so-called early or young onset, you may be also asked about family history if there's very atypical symptoms and you know, very unusual movements, for example, very unusual behaviors, which might suggest a different type of neurological condition or dementia that might be related to genetics or not, okay? Frankly, once you're in your later 60s, 70s, 80s, 90s, it's irrelevant. You probably won't even be asked about family history because, say, you know, even if it's your aunt and your grandmother and your sister and so forth had memory problems as they got older, but they all got diagnosed with these memory problems in their 80s and 90s, highly, highly, highly unlikely to be genetic in any sort of way. We don't worry about that. And then, of course, we want to know generally about the medical conditions, particularly things like stroke, heart attack, and so forth, that can have impact on dementia. And I'll come back to that in a moment. Whenever we're looking at somebody's cognition, we are also, and frankly, as geriatricians, we always, regardless of why the person's coming to us, we must always look at all medications, okay? Because there are some medications that can give side effects of confusion, slowness of thinking, things that can look a lot like dementia. And this includes non-prescription medications, over-the-counter, natural herbal products, so forth, okay? Particularly things that have impact, what we call psychoactive meds, that can have impact on your psychology. So things like sleeping pills, anxiety pills, antidepressants, certain types of painkillers. By the way, though, do not suddenly stop medications if you are on these kinds of medications. Check with your doctor, check with your pharmacist, because some of these medications, if you stop them cold turkey, you can have a withdrawal syndrome and it can be very, very nasty, okay? So, but if you are taking these kinds of pills, for example, over-the-counter sleeping pills, Tylenol, NyQuil, all these things that have night in them. Many of them contain an over-the-counter sedative that can have side effects of confusion, okay? Speaking of which, you'll sometimes hear doctors talk about anticholinergic medications. What this means is that one of the chemicals to communicate between brain cells, so-called neurotransmitters, is called acetylcholine. And what anticholinergic medications are is they block the function of this so-called acetylcholine, which is one of the key brain chemicals in memory, okay? So if you have anti-memory chemical medications floating around, you can imagine then you may have memory problems and confusion. So I mentioned about these night medications, but it can also include some anti-nausea medications. It can also include certain bladder relaxants for incontinence and so on and so forth. So if you're having memory problems, cognitive problems, you're noticing it in your family, it's always a good idea to question, hey, could this be related to medications? Things seem to have particularly gotten worse since that bladder relaxant was prescribed. Hey, doc, hey, pharmacist, could this be related? Okay. We will also ask about how the medications are taken, both in terms of what method is used. Does it come in bottles? Does it come in a pill pack, like a disc pill? Does somebody have to remind you? Does somebody actually give them to you? Because again, what is the functional impact of the cognitive issues, if any? As well as accuracy, what they'll call compliance. Are you forgetting to take the pills? Are you choosing not to take the pills, and in terms of why, et cetera, et cetera. Okay. So a lot of questions may be asked about medications, both in terms of, is there something maybe contributing or causing the cognitive problems, as well as are the cognitive problems having an impact on how you take medications? Whenever we think of medications, though, we also got to think about other things that can have effects on the brain, other substances like alcohol, like cannabis, and so forth, okay? Not necessarily because they're the cause, not necessarily because they have to absolutely stop, but they may be contributing, or in some cases, they actually may be the cause, in which case maybe there's something we can do about it. We will ask questions about safety. Is it possible that, yes, we are all saying there's a cognitive problem here. Could it be putting the person at risk? For example, driving, and that's a whole other talk in and of itself. And it's a very, very touchy topic, because the reality is, yeah, you take away somebody's ability to drive, or permission to drive, if you will. It's not a right, by the way, but you take away somebody's permission to drive, it really can have an impact on your day-to-day life. You cannot just hop in the car and pick up a liter of milk. You cannot just hop in the car and go see a movie, kind of thing. But you are driving this, how many, 100-pound piece of metal hurtling at speeds of, up to 100 kilometers an hour, that can have very, very, very serious risk to yourself and others. And our threshold for saying, hey, is this safe or not, drops, okay? And it's not a personal thing, it's a societal responsibility thing. Similarly with stove fires, obviously this is a risk to yourself, your family, but also if, say, you live in an apartment building, to other people in an apartment building. Getting lost, wandering off. I mean, there was just another situation in the past few weeks of somebody being found outside their residence in the cold winter weather, having, for whatever reason, gone out of their residence for unknown reasons. There was a politician whose mother was found outside her residence, deceased, many, many years ago, similarly. You know, so if this person is at risk of getting lost or has wandered off before, this could be a very serious safety problem, particularly in this climate. Mistaking medications, skipping medications that are critical to maintain health stable, like heart attack prevention, overtaking medications, double dosing, things like that, like on things like insulin for blood sugar and seriously life-threatening drops in blood sugar. These are critical safety issues to know about. A person's ability to call for help if they are in trouble, or, to be honest, if you are, say, the spouse there and you are having trouble, can your spouse with cognitive impairment call help for you, you know? And other things like financial exploitation. These are all kinds of safety concerns we may ask about. And then there are the behavioral and psychological symptoms of dementia. Okay. Bpsd. This is probably the most difficult aspect of dementia to live with, particularly for a person's entourage. Keeping in mind, though, again, red, bold, in italics, what I'm about to describe does not necessarily happen to everyone, okay? Some people don't have any of these. Some people have the opposite of them, okay? So it doesn't mean it's gonna happen. But if it does happen, could this be related to the illness? Hey, doc, hey, nurse, hey, whomever, health professional, I need help. I think this might be related. What are we gonna do about it, okay? Before it does become a big, big disaster, if at all possible. So you may see personality changes. The person may become much more depressed, anxious. They may become more aggressive verbally, even physically. I mean, people who tell me my husband was the most gentle man in the world, and now he's swearing and lashing out at people and trying to hit people. This is not him. That's right, it's not him, it's the illness, okay? Flip side is the person may become much more pleasant, might be much more gentle. You know what? Go with it if that happens, you know? But it may not be normal, interestingly enough. They may have trouble with so-called executive function, and I'll come back to this in a moment, but judgment, insight, initiative, motivation, inhibition, you know, like that filter, they no longer have that filter. You know, mom was always kind of blunt, but oh my God, it's so embarrassing now. We go out in public and she goes up to somebody and says, well, you're fat now, aren't you? Oh my God, mom, I can't believe you said that. Okay, maybe your mom has some issues, but maybe it's changes, cognitive changes in executive function. There may be frank behavioral changes. I mentioned repetitiveness again, not only verbal repetitive, but maybe even repetitiveness in actions. For example, opening windows, just repeatedly opening windows. It's minus 38 with the wind chill. What are you doing? It's sort of a behavior change. I mentioned wandering, shadowing, you know, shadowing, constantly following me around the house. Being very restless, rummaging through things, you know, going through all the drawers, pulling out all the clothes, this and that. Why are you doing this? Hiding things, and then forgetting where they went, and so then accusing people of having stolen them. Hoarding things, okay? There can be other reasons for these behaviors as well, but they might be a sign of BPSD. What can be very frightening sometimes, other than physical aggressivity and so forth, is a person may develop delusions. false beliefs, okay? And they may be thinking these false beliefs, or they may be actually hearing or seeing things that don't exist, okay? So-called hallucinations. Some of them are very common. They misplace something, therefore someone must have stolen it. I can't find my hairbrush, therefore you, son, took my hairbrush. It must be my daughter-in-law. That daughter-in-law, she steals everything. She took my hairbrush. How likely is it that somebody's going to steal your hairbrush, but not, your heirloom watch that's sitting on the dresser, that kind of thing? But this is the person's way of trying to make sense of reality. My hairbrush is not there. I would not have forgotten it somewhere, therefore somebody else took it. It's just trying to make sense of what's going on. And if a person has these false beliefs, if they're seeing, there's people living under my bed is something that I hear them, I see them under my bed, not the apartment downstairs. They are literally under my bed. Okay. And then somebody goes, checks, there's nobody there. Mom, what are you talking about? This is their reality. Okay. So there is no point in saying, no, mom, I told you 6 times, there is no one under the bed. Look, I showed you this and that. And that. Oh, maybe you're right, son. No, there's somebody living under my bed. This is their reality. Okay. So yes, we want to make sure there isn't something else that's causing these false beliefs to have developed. We may need to do something about the false beliefs if it's causing a lot of distress or safety risks. But there's no point in trying to argue it, because that is that person's reality. We'll talk about some other strategies in a moment, okay? And you may have heard of this phenomenon called sundowning. That is, the person's pretty okay in the morning, in the daytime, but as the day progresses, mid-afternoon, end of the afternoon, evening, as the sun goes down, they seem to get more restless, then more agitated, then more aggressive, then they're not sleeping, and then they're pacing and so forth. Sometimes can even, frankly, be sort of a day-night reversal. Exactly why this happens, not clear, but this can be one of the Bpsds we see in dementias. And for more on this, I'll talk about other resources. Alzheimer's Group, AGI, of course, has several resources on this. But this book from Johns Hopkins, I find, is a particularly good book to talk about Bpsd and dementia in general for family members who are living with this. On the physical examination, we are focusing on the neurological exam, looking for the various signs and symptoms that we talked about in the history, as well as signs of other diseases that can cause or be associated with dementia. Things like Parkinson's disease. Are there signs of Parkinson's disease? Is there signs of a stroke? And so on and so forth. We do a more detailed mental status exam, which includes things like mood, but also includes things like cognition and the Bpsd symptoms. And then, of course, we do certain cognitive tests. Sometimes we call them memory tests, but it's more than memory, so-called neuropsychological cognitive screening tests, okay? Anticipate that if you're going to be assessed, that if you're bringing a family member to be assessed for their memory, if they need reading glasses, bring the reading glasses. If they need hearing aids, bring the hearing aids. If they need translation, bring someone who can translate, okay? Ideally, we would have an independent translator, but somebody who can translate at least, okay? And you may see things like the so-called Folstein mini mental state exam. You may have heard about the MOCA, hit the news particularly when it was used in a particular past American president who said, I did perfectly on it and I have no problems. There may be other specialized tests that are done, and there may be even more specialized testing done by a psychologist specialized in neuropsychological testing if these screening tests are not clear. Again, what these are looking for are for objective evidence in different higher brain functions to suggest that, yeah, there is a cognitive impairment going on here, okay? Again, in and of itself does not make the diagnosis, but with the context of the history, perhaps with certain physical examination findings, all of these things may then lead to the diagnosis of dementia. There may be some blood tests looking for certain conditions that might look like dementia. For example, sometimes profound low thyroid hypothyroidism can look like cognitive impairment, but you treat the thyroid and their cognition improves, and so on and so forth. And there may be certain types of brain scans that are done, for example, a CAT scan, a CT scan of the brain, but not necessarily. It depends. If it's very clear from the history and physical exam, blood tests, and so forth, not showing anything else, it may not be necessary to do a brain scan. But when it's less clear, or when there's something on the physical exam that suggests there might be something else neurologically going on, et cetera, then yeah, maybe the doctor will ask for a brain scan or ask for the person to be assessed by a specialist for further assessment, which probably then will include a brain scan. And this includes so-called structural brain scans, just like a snapshot photograph of what the brain looks like. CAT scan being the most common kind, also may be a so-called MRI, but not necessarily. And then they call functional scans, which look at how the brain is actually working. They give, for example, the most common kind is they give, it sounds scary, but they give radioactive sugar. It's not radioactive as in going to cause you to glow or have cancer or something. It's very, very short-lived. But basically what it is that it's sugar. You inject it into the body. The brain, as well as other body cells, but particularly the brain, uses sugar as fuel to work. And so depending on which parts of the brain pick up more of that sugar to show that it's working more or working less, and the radioactivity shows up on this special scanner, the pattern can suggest certain types of dementias, okay? But it's not typical that this is needed, but it might be used if it's hard to differentiate what's going on. There are all kinds of other specialized tests, which I'll skip because time is running on, but most of them are only done in the research setting. And the focus of them are typically looking at trying to identify before things become a full-blown dementia. Are there signs in brain scans, in blood tests, in tests, like a lumbar puncture of the fluid that bathes the brain, in other types of behaviors or whatever kind of thing that can identify earlier and earlier and earlier things that will eventually then declare itself as a dementia. And why do we want to find things earlier and earlier? Is that maybe we can intervene earlier to prevent things from becoming a dementia, or at least slowing the progression to dementia. That's kind of the goal of that. But all of that is pretty much still research. And you can read quite a bit about this from organizations like the Alzheimer's Society. I'll give those links in a moment about what's sort of current research going on, even research trials that may be going on if you're interested. This is not all necessarily done by a doctor or even a neuropsychologist. We often may be having to consult other professionals to see what is really going on, particularly people like occupational therapists who look at a person's occupation, if you will, how they are occupied in day-to-day life. So what's the functional impact? Specialists like speech language pathologists, if there are particular language issues or findings that may suggest a particular type of dementia or another, and then of course, what can we do about that, and so on and so forth. I'm way over my time here, and I apologize for this. Let me just maybe briefly go on for another 3 minutes, and then I think we need to take some questions. But all of this to say that dementia, you notice I haven't used any words like Alzheimer's or Lewy body or these kinds of things that you may have heard of. I've been just talking about this umbrella term of dementia. But there are many different kinds of dementia. Alzheimer's is the most common kind, and it's just a type of dementia that is caused by a certain mechanism. So people often ask, what's the difference between dementia and Alzheimer's? Alzheimer's is just a type of dementia. But there are other kinds as well, which seem to be caused by other changes in the brain that may have different symptoms, at least initially. And why we try to differentiate this is that they might be treated differently, but to be honest, the vast majority of them are treated in the same way. And they might have different symptoms that people need to understand, anticipate, cope with, okay? As well as they might progress at different rates. Certain things progress more slowly, other things can progress more quickly, okay? So I don't know if these slides will be made available to you. I certainly can make them available to you, but I go into more detail in terms of what are some of the features that distinguish one type of dementia from another, okay? So in terms of Alzheimer's disease, most commonly affecting memory, but not necessarily. There's a particular kind, for example, that presents with trouble speaking before it presents with any other symptoms. There are so-called vascular dementias, vascular simply meaning related to circulation to the brain. So this is typically seen in people who have had strokes or what they'll sometimes call mini strokes. So you're fine, you're fine, you're fine. You have a stroke, boom, your cognition changes. That's classic vascular dementia, okay? Lewy body dementia is one that can often get confused with Parkinson's disease because sometimes they can present with symptoms, movement problems like stiffness, slowness of movement that can look like Parkinson's disease, but when you parse it down, this isn't regular Parkinson's disease. And there's a whole bunch of other stuff going on, particularly those false beliefs, the psychotic symptoms of hallucinations, delusions, which can be quite striking and can happen quite early on. It can happen in other causes of dementia as well. Even Alzheimer's can have hallucinations and so forth, but the nature of them tend to be a little different and they tend to be later on, okay? Lewy body can also have tremendous fluctuations. I mean, there are times where the person seems almost comatose and you do all kinds of tests and brain scans and all kinds of things, try to figure out what's going on, and then boop, boop, they're back, they're awake again. What happened? You see that enough times in the constellation of these other symptoms. Maybe this is Lewy body, okay? One that is particularly difficult, not common, but particularly difficult, is the one they call frontal temporal dementia. And the reason being is that it can particularly affect the frontal lobe early on. And that frontal lobe is responsible for those so-called executive functions: insight, judgment, planning, motivation, impulse control, that filter, disinhibition, that kind of stuff. And their memory and their orientation, they know the date, they know the time, the place, they can remember everything, their bills are all paid, et cetera, but they just have no filter, okay? Oftentimes, I've had patients where the family member is like on the verge of divorce or has actually threatened divorce because I can't stand this anymore. He treats me like excrement, she started gambling, just sits there, doesn't care anymore, I don't want to be married anymore, that kind of stuff. But when you dig and dig and dig and dig, you know what, no, this is not like him normally. This all changed in the past year. Do more tests, do more assessment. This might be frontal temporal dementia. And it's really hard for families because not only is it hard for the family to understand, but it's hard for other people to understand. And they think, oh, he's fine, his memory is fine. You don't see what's going on at home. Okay. And then all kinds of other things, which I will unfortunately skip over, but I do have to point out one though, which is alcohol, okay? Chronic, long-standing, heavy alcohol use can cause a specific type of dementia called Korsakoff syndrome, okay? So when we start asking about alcohol use, when we recommend that people cut down or stop using alcohol, this might be one of the reasons. May not reverse what's happened, the damage that's happened to the brain so far, but maybe hopefully prevent things from getting worse, okay? The typical course will vary, okay? And I'll leave all the details there, but the reality is, and I have to speak bluntly, the reality is that things progress, okay? Maybe with the exception of stroke. If it's purely related to a single stroke and then there are no other strokes, it's quite possible that that person will just stay at that level, at least until something else happens. But the vast, vast, vast majorities of causes of dementia, unfortunately, do progress, okay? So we, and again, I apologize for my timing here, but we need to plan, okay? The mainstay of treatment is planning, okay? We need to plan for change, hope for the best, plan for the worst, okay? And we need to plan for progression. When the person's going to need more help, when living arrangements may need to change, when we need to start about things when they get very, very severe, what is it that you want? What is it that the person would want? Okay? These kinds of things do need to be considered. And frankly, that planning and adapting around the changes in the person's functional abilities is the mainstay of treatment. Yes, there are medications. Yes, there are certain lifestyle changes, exercise, socialization, cognitive stimulation, and so forth, that may help to stabilize or slow things down for a period of time. But ultimately, things will progress. So we need to plan, we need to understand, and we need to adapt. That's really the mainstays of treatment. And that's where organizations like AGI, like the Alzheimer's Society, come into play. And to help you understand what's going on, information about the disease, information about the symptoms, is it treated? How do we adapt around it? How do I live with this? How do I access resources in my community, public, private, whatever it is, okay? That's where these kinds of organizations really are instrumental. And support for you if you have cognitive impairment or your family member is really key. If I can just end on one pithy expression, you know, they talk about dementias being a marathon, not a sprint. You know, I hate to say this a little bit, but you know, things like cancer, many cancers, you have it, you're fine, or you're not, kind of thing, or you're fine for a period of time and then suddenly you're not, you know. And people are like, oh, I'll support you all this, I'll fundraise for you, whatever. But when you're dealing with an illness that progresses over 5, 10, 15 years, as some types of dementias may, you know, where did everybody go? You know, they were so around me, they were so helpful. Where are they now, kind of thing. So I recently, in the past few years, started running myself. And I actually did run one marathon, and I'm pretty sure I'm not going to ever do that again. But the reality is if you don't learn about how to pace yourself, about what it takes to run a marathon, you will hit that wall and you will burn out, and things will fall apart, not only for you living with the dementia, but for your person who is depending on you to help them live with the dementia as well, okay? So my super sincere apologies for having taken way too much time. I will make this presentation available for anyone who wants it, but I don't know, is there's still time to take any sorts of questions at all?
Yeah, we can have 10 minutes of questions if that's okay with you.
Yes.
So Dr. Chiu, I just, maybe we can stop sharing the screen if that's, Nin, if you can do that, or Dr. Chiu, so we can see your lovely face a little bit. There we go.
There we go. Okay.
So Dr. Chiu, I just want to say thank you. There's a lot of comments in the chat and Q&A, and people have already reached out to me, but people really appreciate this presentation. It was simple, it was clear. It spoke to what the caregivers are actually feeling, and even the people with dementia. You know, they are doing the best they can, people living with dementia, and a lot of caregivers, you know, not everyone with dementia has insight to their diagnosis. And, you know, a lot of caregivers struggle. Oh, are they just in denial? What if I tell them over and over again? So I really appreciate your presentation and kind of going through the process that it's just not so simple. Oh, I have memory loss, or oh, I'm experiencing this behavior, that that there must be something going on. You talked a lot about the possibilities in getting a proper diagnosis, looking at their history and so forth. You know, I'm just thinking of family members and friends, parents, and things like that. There's a lot going on there, you know, with all the different types of medications. what's the typical length of getting a diagnosis
Ah.
with all of these factors, you know, people with sleep problems, depression, on antidepressants, on taking NyQuil, having some alcohol, and all of these things. And, you know, part two of my question is, you know, some people get diagnosed through the GP, through you know, their general practitioner if they're lucky enough to have one, and then other people wonder, well, should I go to a memory clinic, a specialist? And you talked a little bit about the multidisciplinary team. So I'm just wondering, from your perspective, you know, typically what's the length of getting a proper diagnosis? Of course it varies, and also, can this be done with the GP if they're willing to?
So let me take the second part first, because that's the easy one. Can it be done by the GP? Yes, absolutely. And in fact, the GP, the family physician, is the first line to go to. The government even has a program, they call it the Le Plan Alzheimer and so forth. Things haven't completely rolled out, mind you, but anyhow, it's always a work in progress. But it's supposed to be, and we give similar talks like this to family physicians in their continuing medical education, so that the frontline professionals are more aware of this, are not going to just say, oh, this is old age, or what do you think, or that kind of thing. So that they are more aware, more attuned, more looking out for it, know what kind of questions to ask, know what kind of basic tests to order, and so forth. So the GP is always the first line to go to. Memory specialists, more often than not, are geriatricians, oftentimes, particularly for younger people, for very atypical situations, maybe neurologists, are by referral. Okay, so just because your GP said, listen, I think you have Alzheimer's, it doesn't mean, oh, no, she's wrong, it has to be done by a memory specialist. Not necessarily. It may be very, very clear to your GP. But if the GP is not clear, or we all have to acknowledge our own limits, your GP is not comfortable or does not feel able to diagnose it, then it's very appropriate for that person to then say, you know what, I think it's better to see a memory specialist. So you don't have to see a memory specialist, but you might be asked to. How long does it take to get diagnosed? That's, I think, a big part of why we're having this talk today, because people need to recognize first that this may not just be getting old. Okay. Oftentimes what happens is that people don't seek medical attention because, oh, I'm just getting old. Oh, dad's just getting old. You know, it's not a big deal. Oh, it's fine. It's fine. It's fine. Yeah, but you know, why are you having to do all the finances and give the pills and drive everywhere and whatever? That's not fine, you know, kind of thing. Similarly for physicians to recognize that. The other delay can be, you know, for example, depression you mentioned. It is very, very, it's not uncommon for people to feel depressed when they start sensing that something's wrong, but they can't put their finger on it. So it's quite possible your doctor may diagnose you first with depression. It's not that it's wrong. It's just that that was the first sign that then a dementia was coming down the pipeline, kind of thing. It's not wrong that your doctor diagnosed you with Parkinson's first, and then later on down the line, they said, no, this is Lewy body. It's just how it presented initially, kind of thing. So typically, you know, I'm often hearing that it can be a year, it can be 2 years before somebody actually gets their official diagnosis, depending on what kind of dementia. Some of them are quicker than others. But, you know, I didn't talk about the treatment, but the sad reality is when it comes to pill treatment and so forth, it doesn't make a lot of difference that was the delay. But what it does make a difference in is our ability to plan and our ability to understand what's going on. Before you say that, you know, I want a divorce because you're a SOB kind of thing, maybe this was the illness. Maybe we could have picked this up before it got to that crisis.
So I just have a couple of questions here. Can you predict life expectancy after a diagnosis of vascular dementia? And is difficulty swallowing a sign of dementia?
Okay, so predicting life expectancy, how long you're going to survive, varies between the dementias, varies within vascular dementia, varies from person to person. So it's very, very hard to say. So as mentioned earlier, vascular dementia, sometimes you just have this single stroke, boom, okay? And then things are very, very stable. What the person actually succumbs to has nothing to do with their dementia. It has to do with them having something else like a heart attack or whatever kind of thing, okay? But there are other types of vascular dementia where it is a more sort of a buildup of tiny, tiny little deep strokes that do gradually progress over time. Again, it really varies from person to person and what are their other health issues. So this is a very not satisfying answer I'm giving you, but it can vary. There are other types of dementia though, where things are sadly a little bit more predictable, where things will more rapidly progress. For example, Lewy body dementia, you will see that things from one year to the next do seem to be changing much more quickly. And there are certain very rare causes, certain, for example, infectious causes that can progress very rapidly over the course of months. Everything is variable though. You know, Alzheimer's, we typically say can be like 5, 10 plus years kind of thing, but there are people with Alzheimer's who do progress more rapidly. There are people who progress more slowly. So it really, really varies and depends on what else is going on in a person's health, as well as their support. You know, you can have two people with exactly the same diagnosis, exactly the same severity, but if one person has an entourage that is well supported, coping, their own health is stable and so forth, they may do well a lot longer than somebody else who has no entourage, who has no support, or whose support network is sick or falling apart themselves. And again, we come back to the organizations like today's talk.
And Dr. Chiu, I think that one of the challenges, I know that you skipped through the slides and people are very curious to see what your slides are for planning, but I honestly think that you could give a second talk about planning and looking at that. So, but I always caution people to look at those 7 stages of the disease, because people really, and we could probably have a debate for a while, but people often kind of want to put their loved ones in a box and try to categorize, probably to help them better plan. But because you said it's sometimes so unpredictable because there's other factors, that people are kind of like, okay, the doctor said that my loved one is in stage 6 and this is where I have to be, but other factors come into play. And I said, well, no, they're doing pretty well. It depends on the support and things. So exactly. I always caution families to be aware of, the numbers scale rather than just kind of general, how are they doing based on their baseline and things like that.
Yeah. And I have people who have mild dementia who need to move to a nursing home, not a nursing home, but like a residence. And I've seen people with very advanced dementia who are still living at home. And all depends on the resources. A lot of it depends on the resources, yeah. And the mere fact that somebody has a diagnosis of dementia does not automatically mean, oh my God, you can't live at home, or you must not be touching your finances anymore. No, it depends. There's always this balance between trying to help people, but then also letting them live their life, and quality of life is really what it all comes down to, within the bounds of safety, within bounds of reasonable safety, of course.
Yeah, which sometimes you need the professional to say whether someone's safe or not safe, right?
Yeah, now we've crossed the line, yeah.
Yeah, I think Nan has one last question before we finish.
Yeah, just one last question. Do people who have had several major depressions in their lifetime and that they were never treated have an increased risk for dementia when they get much older?
Okay, so depression or major depressive disorder diagnosed earlier in life is not a strong risk factor for dementia later on. However, developing new depression, like you were never depressed in your life, and suddenly now in older age, you're developing depression, like frank depression, not like I feel kind of blue and sad kind of thing. No, you're being medically diagnosed with depression. There is an association between that and subsequent diagnosis of dementia. Okay, so if out of the blue your older person is diagnosed with depression, it doesn't mean that you're going to get demented, but it means that we need to keep an eye on the cognition, because there may be a link there. But if I may add to that, one thing that is increasingly associated with developing dementia later on is hearing impairment. okay, which is a whole other talk, because a lot of people, my hearing's fine, you know, and meanwhile, you know, like your TV, or your neighbor 3 doors down can hear your TV, and your spouse is going to divorce you, and you can't hear the firemen at the door, and whatever. My hearing's fine. It's not a big deal. It doesn't bother me. The interesting thing is that not only can it affect your social life and your function, and make you look actually a lot more out of it than you actually are. Frankly, honestly, I have been fooled. People with hearing impairment, I thought they were completely demented until I realized, oh, no, it's just your hearing. But there is increasingly an association between uncorrected hearing impairment and subsequent diagnosis of dementia. Maybe it's because the brain loses that input for years and years and years and years. That might be a risk factor for dementia there. So the fact that you've had depression, you know, and in and of itself earlier in your life, that's not my concern. If you are diagnosed depression completely out of the blue in older age, we need to watch cognition, and yeah, correct your hearing. It's worth it.
We get a lot of talks about, you know, questions about hearing. So I think, thank you for addressing that. Dr. Chiu, again, we might call upon you again.
Yeah.
It was extremely informative, extremely simple to understand, clear, but extremely resourceful to families. I just want to let everyone know that tomorrow at 11 a.m. there will be another talk by Kristen Felton, who's a social worker and dementia care specialist from the States. She will talk about behavioral symptoms of dementia and effective ways to respond and manage these behaviors. Please, anyone who needs some support, you can contact AGI. We're here for you to help you, as exactly Dr. Chiu said, plan, and inform yourself and adapt to make it a little bit easier as the journey goes on. So thank you very much, Dr. Chiu, and have a great day, everyone.
Thank you. Happy New Year.
You too. Bye-bye.